It's 12 o'clock. Let's get started. Hello, and thank you all for joining us today. On behalf of the Radiologia Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfari, and unfortunately, Dr. Hilary Humans, who is always here with me moderating this session, she won't be able to join us for now. She's having an IT problem, so maybe later today. So anyways, our guest speakers today are Dr. Rodrigo Aguiar, Dr. Erin Alea, Dr. Paulo Noronha, and Dr. Philip Tierman, who started the OCAD group back in 2003, maybe, I don't know, I'm not sure. Maybe he can tell us later. So we are all very happy to kick off the year with the first session. We focus on sports imaging, and it's going to be like this. The speakers will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the presenters, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiologia Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases almost every day, please consider registering on the OCAD website. I can assure you all that it will be very enriching, as the website is full of cases and videos of lectures and sessions. A quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you all for your understanding, and with that, I will kick off the session. We have the pleasure of having here today Dr. Paulo Noronha. He's a board-certified radiologist with expertise in MSK imaging. He earned his medical degree and completed his residency in diagnostic radiology at the Federal University of Rio de Janeiro. He completed a fellowship in general radiology at Instituto d'Or de Ensino e Pesquisa, where he began to focus on MSK radiology, which prompted him to further his studies with a visiting scholarship at the University of California, San Diego, under Dr. Donald Resnick's supervision. He currently works at Rede D'Or and Proeco, where he also leads the MSK subspecialty since 2020. Please, Paulo, take it away. You're muted. I think I can't hear you. You're not? Can you hear Paulo? I can't hear him.
Okay, can you hear me now?
Yeah, I can hear you now.
Yeah, the mic switched. Okay, thank you, Aline, for the kind introduction. So it's great to be among so many amazing people, and I've learned so much from you and keep on learning. And so let's dive right into my case. Can you see my screen?
Yes, I can.
Okay, and so let's dive right into it. So this case, the clinical history of this patient, we have a 39-year-old male with no previous medical history. He suffered a hyperextension injury to his big toe while playing soccer, and under physical examination, there was tenderness of the hallux sesamoids. An MRI was ordered, which showed these findings. I'm going to just show the findings first without discussing them, and then go over to the anatomy, so that then we can discuss what's altered in this case. So here we have the images. We have this first finding. We have this finding. So this is medial, this is lateral. We have this finding. And on the coronal section, in this slice, we have these findings shown with the blue arrows. So the patient suffered the first MTPJ, the first metatarsal phalangeal joint plantar injury, which is called a turf toe. Here in Brazil, a lot of people don't know what turf means. Turf actually means grass, but it's a term that is often used to refer to the turf fields originally in American football, but here in Brazil, it's more usually related to soccer. The term was coined in 1976 at West Virginia University, related to American football, and attributed to flexible shoes on a hard artificial playing surface. This is an amazing article from 2020 called High Resolution MRI of the First MTPJ by Dr. Helena and colleagues. And I actually like to call this article Ultra High Resolution MRI of this joint, because they used 11.7 Tesla MRI to acquire some of the images they show. So here we have an anatomic section from a different article, and here we have the MRI image from this article. And here's a small meme from The Office. I don't know if anyone watches this show. So corporate needs to find out the differences between this picture and this picture. And then they're actually the same picture, because we can see every anatomical detail in this 11 Tesla MRI image. So here we have a profile view of the first MTPJ. We have the metatarsal head, the proximal phalanx, and here in the helix sesamoid. Here we have the metatarsal sesamoideal ligament, and here we have the sesamoidal phalangeal ligament, and under that we have the flexor hallucis longus tendon, and dorsally the extensor hallucis longus and brevis tendons. Now we're going to ask this lady to see this image from below, and here's what we can see from below, which would be roughly an axial image. Here we have the proximal phalanx, metatarsal head, lateral and medial sesamoids. Between them, we have an intersesamoideal ligament. The stars are showing here the lateral and medial sesamoidal phalangeal ligaments, and between them, we have a fibrocartilaginous structure, which is the plantar plate proper. Further stabilizers of this joint are the abductor and adductor muscles and tendons. Here, the abductor tendon will insert on the lateral sesamoid, joint capped on the medial sesamoid, joint capsule and proximal phalanx. The adductor, which has a transverse and oblique head, will insert on the lateral sesamoid, joint capsule and proximal phalanx. The flexor hallucis brevis muscle has two tendons with a medial and lateral head, which will insert respectively on the medial and lateral sesamoids. And below them, we have the flexor hallucis longus tendon, which passes right between the medial and lateral sesamoids at the region of the plantar plate. Here we have an anatomic section where the proximal phalanx is deflected superiorly and the metatarsal head is deflected posteriorly. Here we can appreciate the lateral and medial sesamoids, the region of the intersesamoideal ligament, plantar plate proper, and the sesamoidal phalangeal ligaments. Now we're going to ask Superman to use his X-ray vision. Nowadays, I think it would be much better if Superman had an MRI vision, because that would mean less ionizing radiation every time she uses it, and superior soft tissue contrast. And here we can see now a schematic and the MRI image of this article with the 11.7 Tesla ultra high resolution image, showing on the coronal slice, dorsally the extensor tendons, and plantarly we have the lateral and medial sesamoids, intersesamoideal ligaments, and from the metatarsal head, both medially and laterally, we have the metatarsal sesamoideal ligaments. And here in the MRI image, we can appreciate all of these structures. And here more medially, we can also see the adductor hallucis tendon. And here we have some more images from this amazing 11 Tesla MRI. Here on an axial slice, we can see the sesamoids, lateral medial, intersesamoideal ligament, and the plantar plate proper. On the sagittal slice, we can see the plantar plate proper, the flexor hallucis longus tendon gliding below it, and dorsally the extensor tendons. On a more medial slice, we can see the medial sesamoid and the sesamoidal phalangeal ligaments. Here on a coronal slice, we can see the medial and lateral sesamoids, flexor hallucis longus tendon, and here we have the abductor tendon inserting on the lateral sesamoid, which will blend then into with the lateral capsule and insert on the base of the proximal phalanx. On a more lateral slice, we can appreciate the lateral sesamoidal phalangeal ligaments. These are more proximal slices. This is the one I'm going to go through. We can see a more proximal part of the metatarsal head. Here we can better appreciate this part of the adductor tendon, and both of the heads, the oblique head and the transverse head, of the abductor muscle and tendons. And here we have the flexor hallucis tendon passing more in a more median place. So going back to our images, so this is our first finding. So we have a marrow edema at the dorsal aspect of the proximal phalanx of the hallux. Second finding, here we have the medial sesamoid, here we have the lateral sesamoid, and we can see there is disruption of the sesamoidophalangeal ligaments. The medial sesamoidophalangeal ligament has a gross discontinuity, but there is altered signal and irregularity of the lateral sesamoidophalangeal ligament. We have a coronal slice at the level of the sesamoidophalangeal ligaments, which show a gross disruption of both of these ligaments. Here we have a T1, a T2, and a PD fat set weighted imaging showing disruption of both of these ligaments with surrounding inflammatory changes. Finally, a last finding of this joint, we had a questionable cortical irregularity at the plantar proximal phalanx. A complementary CT exam was ordered, which showed a small cortical avulsion at the plantar plate proper insertion at the base of the proximal phalanx. So this case is a classical turf toe injury with a bone contusion at the dorsal proximal phalanx, as shown by the green arrow, tearing of both lateral and medial sesamoidophalangeal ligaments, shown by the orange arrows, and the cortical avulsion at the plantar plate proper insertion at the base of the proximal phalanx of the hallux. So the take-home points, this first metatarsal phalangeal joint has a complex anatomy. This nomenclature is somewhat inconsistent, but I think this article does a great job in describing and going through all those details. And familiarity with this anatomy enables precise description in the setting of injury, which enables optimal treatment choices. This is my bibliography. Thank you very much.
Thank you very much, Paulo. Yes, indeed, beautiful images from the article and beautiful case. Thank you. So now I'm going to introduce Dr. Philip Tierman. He's an internationally recognized expert in applications of MRI for evaluating orthopedic, sports medicine, and spine disorders. He's the co-author of 3 textbooks, including MRI of the shoulder and diagnostic imaging orthopedics. He's also the author and co-author on over 60 original scientific articles published in the radiology and orthopedic literature. A native of Arkansas, Dr. Tierman attended both college and medical school at the University of Arkansas. He did his radiology residency at the University of Texas Medical Branch in Galveston, and did fellowship training in MRI at Cottage Community Magnetic Resonance Center in Santa Barbara, and at San Francisco MRI Center in San Francisco, where he continued to practice and was named medical director. Dr. Tierman was subsequently recruited from SFMRC to the prestigious National Orthopedic Imaging Associates Group. Dr. Tierman is a widely sought lecturer and has spoken at over 50 international meetings and was the founder of the online MSK forum, OCAD, One Case a Day. Dr. Tierman is also food and wine connoisseur and is the author of the popular book, The Wine and Food Lover's Diet, which was a James Beard Award nominee. Please, Philip, take it away.
Thank you very much. Thanks so much for that nice introduction. I'm going to try and figure out how to get my case up here. I'd like to welcome everybody for joining us this morning. OCAD has really become an interesting place to be and a very useful resource. It started out as a simple email chain back in the late 1990s when I was in San Francisco. And it's really morphed into what it is today, a teaching resource, a repository of cases, and also kind of a consultation service that anybody from around the world can take advantage of. So that's a very, very exciting thing. And I want to thank the Radiological Society of Rio de Janeiro and Aileen, especially for helping put this together, and Hillary Humans, who is our first president of OCAD. And she's just been fantastic. And a lot of OCAD today is because of her vision. So, pardon me. What I want to do for the next 10 minutes or so is present a case that I found really interesting that I saw just a couple of weeks ago. I'm reading cases now teleradiologically from not only California, but the middle part of the country. And this case came from an indoor sports injury, which was basketball in Tennessee. It snowed in Tennessee just a few weeks ago, and so a lot of indoor sports activities were happening. And this is the history as I received it when I opened up the case. It was a jamming injury of the fifth, what they said was pinky finger, which is the fifth finger, in basketball 2 weeks prior. The patient has an inability to extend the PIP joint, so it's kind of locked in flexion at the PIP joint. And so the orthopedist said, well, we've got an acute boutonniere's deformity, and the patient's got continued limited mobility. So I'm going to show you the images without pointing out the pathology, so you can take a look at it. What we're doing, this is a T2 weighted sagittal image of the fifth finger of this 16-year-old boy. And here's the radial aspect of the fifth finger. Here's the midline, or close to midline. And here is...
Philip, I can't see your presentation.
Now, how are we doing?
Great, thank you.
I apologize for that.
Okay.
I get the excuse of it's still early in the morning here. All right, well, 16-year-old male jammed his finger in a basketball injury 2 weeks ago, can't extend the PIP joint, had what was described as an acute boutonniere's deformity with continued mobility. Here are the sagittal T2 weighted images. We're going to go from the radial aspect to close to midline and just a little bit ulnar to the midline in this image right here, T2 weighted sagittal image. T1 weighted sagittal image at the same locations, just radial, midline of the fifth finger, so mesial portion of the fifth finger, and just a little bit ulnar to the midline of the fifth finger. In the axial plane, we've got T1 weighted images showing proximal to the PIP joint. This is the PIP joint itself, and just a tiny bit distal to the PIP, so really in the same location. Proton density fat saturated axial image at the level of the just proximal to the PIP joint and at the PIP joint itself. What I ask our technologists to do is to always include a normal finger anytime you're doing an image of a finger, just so you can have something to look at that you know is normal, and it hopefully will help dissect out what is abnormal. So before we get into the findings and the pathology, I just want to review briefly the pertinent anatomy of the finger. On the extensor side, we have the extensor tendon complex, which is the common extensor tendon with a central slip that inserts onto the base of the middle phalanx. We've got lateral slips that join together to insert on the distal phalanx, and that is the terminal slip. At the level of the MCP, or the metacarpal phalangeal ligament, we have the extensor expansion, which helps us solidify the extensor mechanism at the MCP. And that includes the sagittal bands. At the PIP level, we have something that is a lot like the sagittal bands, but it's not strictly called the sagittal bands, and that's the extensor hood. On the flexor side of the fingers, we have the flexor tendons and the pulley system, which are made up of the annular pulleys and the cruciate pulleys. The A1 annular pulley is just proximal to the metacarpal phalangeal joint. The A2 annular pulley is longer, and it's at the base of the proximal phalanx. We've got cruciate, which means crossing, cruciate C1, which is after A2, and then the A3 pulley, which is pertinent in this case, which is at the palmar aspect or the volar aspect of the PIP joint. Now the findings in this case, we're going to go from the radial aspect of the fifth finger. Notice that there is a defect of the extensor hood just radial to the common extensor tendon at the level of the PIP joint. Also notice that the flexor tendons at the level of the PIP joint are a little bit what are called bowstringed. That's B-O-W-S-T-R-I-N-G-I-N-G. So bowstringing, just like a bow and arrow, where you pull back, the flexor tendons would be the bow, and it's not adherent to the undersurface. I'll show you a normal in just a few minutes. And you can see that the extensor tendon itself is actually intact, and along the ulnar aspect, it's also intact. T1 weighted images show the same thing, a defect of the radial extensor hood, analogous to the sagittal band. We've got really pretty marked bowstringing of the flexor tendon complex, and a lot of space beneath the distal aspect of the proximal phalanx. And then we have an intact ulnar extensor hood. In the axial plane, proximal to the PIP, you have an intact extensor tendon. At the level of the PIP, there's a defect of the extensor hood with an intact central extensor tendon, and you've also got tearing of the pulley. Here is a normal pulley in the normal finger, the fourth finger, that you can see in this case. But if you look at the pulleys in the fifth finger, they're torn. At the level of the PIP, there's a defect of the extensor mechanism just radial to the central slip of the tendon. And on this fat set sequence, you can see the same thing, a defect with separation of the extensor mechanism. One thing I needed to point out is that the PIP joint is actually flexed. And so that's what they clinically saw was the boutonniere's deformity or flexion of the PIP joint. Now, this was given an initial diagnosis of a jammed finger. Jammed finger is a fairly recent designation in the radiology literature anyway. And it's more really of a clinical presentation and a clinical concept. And that is pretty much an axial load. Now, pure axial load is not that common, but it does occur. And that's what's termed a jammed finger. And it can have a varied appearance because different structures can be injured. The tendons, typically with a pure axial load, it's either a subluxation or dislocation of one of the joints of the fingers, injuring the collateral ligaments. And but it's kind of rare or unusual, in my perception, to have a pure axial load, and oftentimes there are torsion type forces that are associated with the axial load. So jammed finger is kind of a loose designation, and it can also be accompanied by many other things, like in this case where we have a boutonniere's deformity and we have a pulley injury. Here was a diagnosis of a jammed finger that resulted in collateral ligament damage at the MCP joint. This is another patient. So in this case, what we have as the official diagnosis is pretty complicated sounding, was a radial extensor hood rupture, just radial to the extensor tendon with an A3 pulley tear, resulting in an acute boutonniere's deformity. And we also have flexor tendon bowstringing. The tendons themselves were actually intact. And so if you think about the mechanism that caused this, it was a pretty complex mechanism. It had to be an impact on the flexed PIP joint that caused forceful extension on the dorsal aspect, and that caused the eccentric rupture of the extensor hood. So just radial to the actual extensor tendon, and that allows the boutonniere's flexion deformity. And then the flexor tendons actually remained tight or taut when the extension force was applied, causing the pulley rupture, just like full body weight or extension on the flexed tendons, similar to rock climbing. So I'll just show you a quick example, and let's talk about this for just a moment. What causes flexion deformities? It's typically something wrong with the extensor mechanism, because if the extensor mechanism is not functioning, then the joint, in this case is a DIP, won't be able to maintain extension, and it will be either locked in flexion or at least passive flexion when there are no forces put across it. If it occurs at the DIP joint, it's known as a mallet finger. If it occurs at the PIP joint, it's known as a boutonniere's deformity. And in this case, it was a boutonniere's deformity because the extensor hood was ruptured, and we have loss of extension at the PIP joint. Pulley injuries are on the other side of the finger, so on the flexor side, and these have been graded clinically from 1 through 4, grade 1 being the least severe injury, and that's seen as a pulley strain. Grade 2 is a rupture of A4, which is a more distal pulley. You can see in this diagram, or a partial tear of A2 or A3. And then a grade 3 rupture is ruptured A2 pulley or A3 pulley. And in this case, it can still be treated conservatively. Multiple pulley tears require surgery. And how do the pulley injuries come about? It's marked extensor strain on flexed digits. And I found this kind of interesting. This fact is that there are different grips that are used in rock climbing, and you can analogous injury would be what we have in this case, where the patient must have been flexed when forceful extension was put on. And this type of grip, called the crimp grip, which is really forceful flexion at the PIP joint. I don't know why that's happening. Actually exerts a lot more force on the PIP joint than the simple distal grip that we see here. And so analogous to a fishing line, if you've got a lot of weight of a big fish, you're going to put some strain on these flexor tendons, and that can rupture actually the pulley. Here is a case of an A2 pulley injury. Notice the normal at the proximal phalanx injury, proximal phalanx level. And here's the injured A2 pulley where we have bowstringing. And for the last slide, since I think I'm pretty much out of time, we've got a normal pulley here, ruptured pulley. So the axial plane is very, very useful in showing a ruptured pulley. And one can also see in the sagittal plane bowstringing. And then what I was doing with one of our hand surgeons was to actually try to image inflection. And when you've got a pulley injury, it actually accentuates the bowstringing and shows it, I think, a little bit better. So the A2 pulley should be here, and you've got nice bowstringing right there. And what the surgeon did was to go ahead and harvest the palmaris longus tendon, and then do an A2 pulley repair surgically. So the last concept I'll give you is other deformities that don't involve the pulleys, and that would be the jersey finger, which is a tear of the flexor digitorum profundus tendon, and it can retract all the way into the palm or lesser. And I'll just end it with this one image of a type 1 jersey finger where you can actually see the tendon retracted all the way into the palm. So the purpose of me showing this case was to show one complex injury that occurred in the 5th finger of a young 16-year-old that came with a diagnosis of a jammed finger. And it turned out to be a more complex injury, being both an extensor hood rupture, allowing the acute boutonniere's deformity to be shown, and also rupture of the A3 pulley, allowing the bowstringing that we saw on the MRI. So I want to thank you very much for your attention, and hopefully I didn't go too far over time. And I'll look forward to any questions that might come up at the end. So thank you so much. It's our dog Buster. He's a rescue, half coyote.
Thank you, Philip. Can you hear me?
I can.
Okay. Okay, thank you. So now it's Dr. Erin Alea's turn. She's an assistant professor of radiology at NYU Langone Medical Center and a member of the NYU Langone Medical Center division of MSK Radiology. Erin graduated from Pennsylvania State University in 2006 with a BS in biology and earned a medical degree in 2010 from NYU University School of Medicine. She completed an internship in medicine at Lenox Hill Hospital, New York in 2011. Dr. Alea completed residency in diagnostic radiology at Montefiore Medical Center, where she was elected and served as chief resident. Following residency, she completed a one-year fellowship in diagnostic and interventional MSK radiology at NYU Langone Medical Center in 2016. Please, Erin, share your screen.
Okay. Thank you for the nice introduction. Let me just, okay. All right, are you seeing my screen okay?
Yeah.
Okay, awesome. So I'm excited to be here today to present what I think is a very interesting MSK sports case. Okay, so our patient is a 24-year-old female who presented after a soccer buckling injury. So importantly, this patient is just 24 years old, but has had 3 prior ACL reconstructions. So on clinical exam, our surgeon was concerned for a possible repeat ACL graft tear, meniscal pathology, and a possible posterolateral corner insufficiency. So we did the MRI, and the MRI was diagnostic of a complete ACL graft rupture. And here you can see complete disruption of the proximal ACL graft fibers. Now, because of the complete ACL graft tear, the patient was therefore indicated for a revision ACL reconstruction. But this is not a straightforward revision ACL reconstruction. Remember, this patient has had 3 prior grafts, and she's only 24 years old. So our surgeon wanted to optimize this patient to prevent any further graft tears by looking carefully at her anatomy, any intra-articular, extra-articular pathology, and technical features that could be contributing to so many graft tears that this patient has had. So the preoperative imaging workup is going to be really important in patients like this. And so to kind of get into the mind of our surgeon, what they're thinking about when they're working up a revision ACL graft failure, there could be technical contributions, unrecognized injury to ligaments or the meniscus, and finally malalignment. I'm going to be going through each of these. So from a technical standpoint, routine knee radiographs are going to be really important. And we can see here that the hardware is in standard position. We have a nice position of the femoral interference screw and this cortical fixation button. The routine knee radiographs are great for looking at position of the tibial and femoral tunnel. So we see the tibial tunnel is entirely posterior to where Blumensatz's line intersects the tibial plateau. That looks great. And then the femoral tunnel, what our surgeons use is what's known as the Bernard and Hertel quadrant, looking at the normal position of the ACL footprint at the level of the femoral attachment. It should be just inferior to the most superior posterior square right here. And we can see here our femoral tunnel looks great. So for these patients, the surgeons often will also order a CT with 3D reconstruction. So we're looking at tunnel position, which we've already assessed and we've decided that it looks pretty good, but we also do these 3D reconstructions and we subtract out the medial femoral condyle. And here we're left with an image of the lateral femoral condyle. This is showing us the aperture of the femoral tunnel. Here you see the interference screw. And I'm not seeing any excessive widening of either of the tunnels. If there is excessive tunnel widening more than 14 millimeters, these patients may be indicated for a two-stage revision. The first stage where the tunnels are narrowed with bone graft, and then the graft is revised. So we've ruled out any technical feature that is contributing to her recurrent graft failure. Next, let's look at any unrecognized injury. Any ligament injury that could contribute to recurrent graft failure is most often going to be posterolateral corner tear or insufficiency. This patient's posterolateral corner looks perfect. So the posterolateral corner is intact and it's not contributing to recurrent graft tear. So next, we look at the menisci. So on this MRI, the patient's menisci were read as normal. Our surgeons know now in any patient that has a native or ACL graft failure that intraoperatively, they're going to look carefully for a ramp lesion or a tear of the posterior horn of the medial meniscus that occurs at the level of the meniscocapsular junction. Here we're seeing a vertical fluid-filled cleft at the level of the meniscocapsular junction. This is going to promote anterior tibial translation that can contribute potentially to ACL graft failure. So this was seen in retrospect, but it was not diagnosed at the time of MRI imaging. And then finally, we need to look at alignment that could be contributing to graft failure. So alignment not only in the coronal plane, but also in the sagittal plane. So I don't know about all of you, but at our institution here at NYU, more and more our surgeons are ordering these standing lower extremity alignment films in patients with knee pain. What do? I determine the mechanical axis where it traverses the tibia. And here I draw a line from the mid portion of the femoral head to the midline tibial plafond. I can see here that it's intersecting the lateral tibial spine. So this patient's coronal plane alignment is fine. She has a slight physiologic valgus. What do our surgeons not want to see in these patients? Varus alignment. And as you can see here depicted in this illustration, varus alignment is going to stress. It's going to pull on the proximal aspect of the native ACL or the graft, potentially contributing to failure. It's also going to stress the posterolateral corner structures. So this patient's coronal plane alignment was fine. So we're finally left with sagittal plane alignment. And here's a lateral view of the lower extremity. And we found what could be contributing to this graft failure. She has an excessively increased posterior tibial sagittal slope. So this is something that it's not really widely discussed in our literature. So I created these illustrations. So here for your reference is the normal appearance of the tibial sagittal slope. And in contrast, here is what excessive sagittal slope looks like. The posterior margin of the tibial plateau is tilted downward. And with an axial load that comes through the joint, this is going to promote anterior tibial translation. It's going to allow the femoral condyles to slide posteriorly. And as you can imagine, this is going to stress the ACL. So sagittal slope is something that needs to be measured when you can see ideally the entirety of the tibia, or at least about 15 centimeters. And you can see here, here's a measurement. You determine the anatomic axis. I draw a line at 5 and 15 centimeters down the shaft from the articular surface, get a 90-degree angle and measure the angle between that and the tibial plateau. And it's about 14 degrees. And you can see here how it's much better appreciated when you can see more of the tibial shaft when compared to the same patient's routine lateral knee radiograph. And when we zoom in, again, we can nicely see that excessive increased posterior tibial sagittal slope. Now, you need a perfect lateral view of the tibia, where you can see both the concave medial plateau, the convex lateral plateau, superimposition of the fibula, not necessarily a perfect lateral view of the femoral condyles. So here, just to illustrate and to remind everyone, I don't measure the slope, the sagittal slope on an MRI. We're not seeing enough of the tibial axis to really get a good, accurate measurement. But to just understand the biomechanics of this, just remember that the medial tibial plateau has a concave morphology, whereas the lateral tibial plateau has a convex morphology. And it's thought that that convexity along the lateral tibial plateau is going to permit the condyle to translate posteriorly. And that's why the lateral slope may be more important biomechanically. Now, these patients that have an altered slope and they have recurrent ACL failure, they often will have an abnormal medial and lateral slope. You can measure either one. In the literature, you're going to see more, the medial slope is going to be reported because it's found to be more reproducible. And importantly, the medial slope is going to measure several degrees more than the lateral slope. So this paper in AJSM kind of stresses the importance of the abnormal posterior tibial slope in promoting ACL graft failure. And they found that a medial posterior tibial slope of 12 degrees or more is going to be the strongest predictor of repeat ACL injury. And because of this importance, this excessive increased posterior sagittal slope is therefore going to be a possible indication for anterior closing wedge tibial osteotomy. So this is in the patients who have repeat graft tears. And this image just kind of illustrates the importance of tibial sagittal slope. So the tibial sagittal slope here is going to be the hill. The femoral condyle, you can imagine, is the boulder, and the man here is the ACL. So if you have pathologically increased slope, a steep hill right here, an intact ACL is going to be able to prevent the femoral condyle from translating posteriorly, but the ACL is still going to be stressed. If you have both a pathologically increased slope, a very steep hill, and your ACL is out, the femoral condyle is going to be free to slide down the hill posteriorly. This force is only going to be alleviated by performing this anterior closing wedge osteotomy, making the hill less steep. So contraindications to the anterior closing wedge osteotomy are coronal plane malalignment. So if you have varus malalignment, for example, an anterior closing wedge osteotomy only addresses sagittal plane malalignment. When you do an anterior closing wedge osteotomy, you're going to have more posteriorly directed force of the tibia. So, in a patient with posterior cruciate insufficiency, this is not going to be a good surgical option. And you're going to have more contact pressure in the patellofemoral compartment. So not a great choice in patients who have advanced patellofemoral compartment osteoarthritis. So this patient, due to her excessive sagittal slope, recurrent graft failure, she was indicated for a revision ACL reconstruction and an anterior closing wedge tibial osteotomy. So here is a diagnostic arthroscopy. You can see here, this is the lateral femoral intercondylar notch showing absence of ACL graft tissue. Again, confirming what we already knew from the MRI, that this patient has a complete graft tear. Here is where the meniscal ramp lesion was diagnosed arthroscopically by our surgeon. It was probed, it was found to be unstable, and it was subsequently fixed. And finally, here we have the anterior closing wedge osteotomy. So a wedge of bone is subtracted from the anterior tibia. That wedge is outlined here by the K wires. And here's the immediate postoperative image after the anterior closing wedge osteotomy with metallic staple fixation. You can see here normalization of that sagittal slope. But it's even better depicted when we look at the entirety of the tibial shaft. Pre-osteotomy, you can see that abnormal, exaggerated slope, and here it's been normalized after the anterior closing wedge osteotomy. So I have to give credit to Mike Alea. He's an excellent sports surgeon. He's also happens to be my husband, but this is his case. This is more of a novel surgical technique. It's not often performed. Mike has expertise in multi-leg knee injuries, complex revision for grafts. So thank you guys, thank you everyone for your attention. Please email me if you have put any questions in the chat, if you have any further questions. And here's my Twitter profile. So thank you.
Thank you very much, Erin. I do have a question, but I wait for the last speaker. So next speaker is Rodrigo Aguiar, a very good friend of mine. Now it's your turn, Rodrigo. I'm introducing you before. So he's an adjunct professor of MSK Radiology at the Federal University of Paraná, South Brazil. He completed the residency at Hospital das Clínicas at the Federal University of Paraná, and he did his MSK research fellowship at the University of California, San Diego. He's a practicing MSK radiologist at DAPI Clinic in Curitiba. And he's very involved in MSK radiology education, having presented at radiologic national and international conferences. He also authored several peer-reviewed scientific articles and co-authored book chapters. Please, Rodrigo, take it away.
Hi, everybody. Thanks, Aline, for your kind introduction. And it's going to be a great responsibility for me to wrap up this meeting today, because all the other presentations, they were awesome and they were excellent. And so let's go to the case. Let's just share my screen. Okay, can you see the screen?
Yes.
Okay, so today, ladies and gentlemen, we have a tennis case. I'm going to present a case about this tennis player here. He's at the time of the injury, he was an 18-year-old professional tennis player, and he was playing tennis for 8 years. And his training routine was like 6 hours a day. And he presented with right elbow and distal arm pain for 3 weeks. So that is his clinical profile. And when we go to the images, he went to us, the MRI of the elbow was performed. And first, when you have a professional tennis player, an elite tennis player, we think about some specific pathologies, and first ruling out the more common disease that we can find nicely in this article here, for example. And the extensor tendons were okay, so the lateral epicondylitis or tennis elbow is out. Flexor tendons tendons, it's also okay. So the medial epicondylitis is out. There's no medial epicondylitis. The ulnar collateral ligament, it's okay, a little bit thickened, but it's okay. There's no rupture, no T sign, nothing like, there's no rupture here. So the ulnar collateral insufficiency is out. And continuing on, no posterior medial osteophyte on the axial plane. I couldn't see that either. So the valgus extension overload is out of question. And also in the sagittal plane, you can see that the capitellum is okay. So osteochondritis is seconds. It's out in this case. But, and there's almost always a but, we can see that there is a high signal intensity on fluid sensitive sequences on the medullary bone of the distal humerus. Here you can see this high signal intensity in the medullary bone, and we extended the exam to the arm. And when we did that, we found this high signal intensity on fluid sensitive sequences on the distal, the middle and the distal diaphysis of the humerus. Okay, so this is the T2 sequence with fat suppression showing this high signal intensity, this bone marrow edema in the distal portion of the humerus. And here in is the axial plane, T2 fat suppressed images and T1 fat suppressed images. And we can see a cortical thickening of the humerus, linear periosteal reaction, and also some areas of intermediate signal on T1. Okay, so he's a professional tennis player and no signs of cortical break or soft tissue extension. And the diagnosis was a humeral stress reaction in an elite tennis player. Okay, and this is a condition that was kind of first described in 2006. This paper here, they described 8 patients, 8 elite athletes, tennis players from the Australian Open 2002. They had pain in the dominant arm, the same quantity, the same amount of male and female patients, and they had bone marrow edema and periostitis. The same group, few months later, they also published this paper on the AJR. They use part of these patients and more 4 patients from the Australian Open of 2002 and 2003, and they elaborate a little more about this stress reaction of the distal humerus. And also in 2007, another group from Brazil, they also described 5 patients, 5 tennis players with this kind of alteration. And there is a good paper from 2020 talking about doing a review about many lesions, the lesions that can compromise the upper limb of the elite tennis player. And when they talk about this humeral stress reaction, and the players, they have increasing pain when serving, palpable pain over the distal humerus, and a positive humerus squeeze test, medial-lateral palpable squeeze test, and an anterior-posterior squeeze test, positive squeeze test, and they could find that the pain, it's a little bit higher than the elbow. They go to the elbow, this pain, they go to the elbow, but also it goes to the distal third of the arm. And when we took at that time, when we took a look at the axial image, we could see this small dot here in the cortical bone. Okay, and the doubt was if it could be a osteomosteoid. Okay, osteoma. And did I mention that the patient, the father of the patient, he's a doctor, or he was a doctor, and not just that, he's also an orthopedic surgeon, so no pressure on this case. So we did an CT of the arm, of the humerus, and we could see the thickening of the cortical bone. This is a vascular channel, and we could see a small area of lucency here. And in the axial plane, we can see a small, incomplete fracture of the cortical bone here in this area. So this was a case of a humeral stress reaction and an incomplete stress fracture in an elite tennis player. And after 6 weeks of resting, he returned gradually to his training routine, doing rehabilitation and correcting his kinetic motion, and he had no more complaints on the follow-up. So it was a humeral stress reaction with an incomplete stress fracture in an elite tennis player. The only case that I found showing a stress fracture in the humerus in a tennis player is this one from 1985, showing on the CT this line of fracture right here. So that was the only report on the literature that I found about that. And what's the cause? What caused this stress reaction in the humerus? Or who are you going to blame? I like more the second question. Who are you going to blame? And blame the serve. The problem is the serve. It's the most energy demanding motion. It comprises 45 to 60% of all strokes in a tennis match. The kinetic chain motion must be perfect, and it can be affected by previous conditions like shoulder disease or elbow disease. So the athlete doesn't have this perfect kinetic chain motion, so it can overload the humerus. And for example, or improper biomechanics, for example, improper knee flexion, mechanical loads transmitted to the shoulder and elbow increases by 17 to 23% if you have an improper knee flexion during the serve. So you have to, the tennis player, he has or she has to have a perfect motion in order to avoid this kind of injuries. And here, what happens is this: the elbow in this phase here, during the late cooking and the acceleration phase, the elbow and the shoulder, they go together in external rotation as a team. And here in the late cooking, in the beginning of the acceleration phase, the elbow continue going on external rotation and valgus, going backwards, and the shoulder starts to change in direction, go to internal rotation, okay, to move forward with the arm. And it is in this moment here, that's when this high humeral torsional stress, that's when it happens. And I recorded a video here trying to explain that. So here's like the shoulder, the elbow, the humerus here. So first we have this wind up and early cooking phase of the serve, and the shoulder and elbow, they are in external rotation. And after that, the late cooking phase here, look, the shoulder starts to internal rotate, and it starts before the elbow. The elbow, it's still in external rotation, going backward in valgus. And look, and that's the moment when these high torsional forces are applied to the humerus. And you can see here in this, that my tower serving as the humerus, showing these torsional forces. So that's when these torsional forces, they are transmitted to the humerus, especially to the middle and to the end part of the humerus, and it can cause the stress reactions. So we can see that in the different sports when the athlete has to throw the ball, for example. So we can see that in cricket, in softball, American football, baseball, dodgeball, and it's not just a thing that occurs with tennis player, but actually with other sports, for example, softball, baseball, dodgeball, you can have some it can evolve to fracture. Here, look, it's the same mechanism in the throwing athlete. The difference here is that in the throwing sports, the mechanism is a little bit more violent, because when you are throwing something, you doesn't have to think about a ball. And like the tennis player, he has to think to mind the ball, to reach the ball, and so he has to control more the movement. But in throwing sports, the movement is more violent, and it can cause fractures, spiral fractures of the humerus, and this is the thrower fracture. Okay, so it can happen also like with soldiers. For example, in this paper for 1971, from soldiers from throwing hand grenades. So not just in sports, but also in war, but sometimes sports and war, they are the same thing. And just to put the icing on the cake, or in Brazil, a cereja no bolo, we also, this patient also performed an X-ray, and in the X-ray, we can see that the right humerus, it's much more developed than the left humerus. That's his hand, dominant hand. That was the hand that we could find the fracture, the fracture, and look the bone asymmetry here. And there is it's something that's very well described. The upper limb muscle and bone asymmetries and bone adaptation in tennis players, especially in elite youth tennis players. And there is a catch name for that, for this asymmetry of the limbs, and that's the King Kong arm. So the King Kong arm is the nickname for the overdevelopment of the dominant arm and shoulder in tennis player. You see, it's also known as the unilateral muscular hypertrophy, but that's the boring term. King Kong arm, it's much nicer. And there's another definition about the King Kong arm that goes with this one too. And that's it for this presentation. I just presented an unusual condition, but I think that's underestimated, this condition. We have to keep a look on that. And we don't find this condition in some of the good articles. I reviewed many papers, good papers, and they don't talk about that, just few ones. And we also used this condition to understand the mechanism of lesion in the tennis, and also how we can extrapolate that for the other sports, the throwing sports. And that's it for this presentation, and I'm open for questions too.
Thank you all. What a great session today. Fantastic case and discussion. Thank you so much. For now, I don't see any questions here, but I do have a question to Erin. There are a few studies on how to measure tibial sagittal slope on MRI, but are these already validated? And I mean, can we reliably use it? Because I saw your surgeons ask for radiographs and in order to measure it. So how is it done in NYU? And
so, yeah, that's a great question. There are some studies that have measured the sagittal slope on MRI, but if you look at the images in those studies, they include a good portion of the tibial shaft, and at least our routine knee protocol barely goes beyond the proximal metaphysis. So a reading on our knee MRI would be pretty inaccurate. That's why it's really, you need to see at least, they say 15 centimeters of the tibia to get an accurate measurement, ideally the entirety of the tibial shaft. So there have been studies on MRI, but really the radiographs are going to be the best measure.
Okay, thank you. So there's a question here for the first case, for Paulo's case. It's from Matt's iPad. So, hi, I'm Dr. Gassep. In the first case, are there any enthesitis of the LHET, Paulo?
That would be the, I'm not sure what the
LHET?
the hallucis extens, longus hallucis extensor, maybe?
Yeah.
I think so. I'm gonna just take a quick look over it again. There was a lot of inflammatory changes around the MTPJ. So the longest, just let me open the case again. I had already closed it. I'm not sure if you're referring, I think it was more probably a bone contusion and not an enthesitis due to the traumatic nature of the injury. I'm just going to take a quick look at it again. Should I share my screen again?
Yes.
I'm just going to share this real quick.
Yeah.
So here actually we have the extensor hallucis longus tendon inserting at the base of the distal phalanx. And here we don't see a lot of change. And here is actually inserting proximally is the extensor hallucis brevis tendon. And here we attributed this to a bone bruise or a bone contusion after the hyperflexion injury. So I wouldn't call this enthesitis due to the traumatic nature of the case we're seeing here.
Okay. Thank you, Paulo. This is from Pablo Brandifo. Good morning for Dr. Tillman. Which coil do you use for performing MRI of a flexed finger? Do you use measurement criteria for diagnosing partial pulley tears? And is it possible to see flexion deformities in cases of partial tears of central or terminal slips? Thanks.
Let me share my screen here. Can you hear me?
Yeah.
Okay, fantastic. Those are good questions. Which coil do you use for performing MRI of a flexed finger? What that case that I showed was done at our local center here, and we use the knee coil. I think there are different choices you can use. If you can use a wrist coil and get the finger in there and flex it, that would be great for a small field of view, but I don't really think that's possible. So we use the knee coil. Head coil would also work. Do you use measurement criteria for diagnosing partial pulley tears? I don't really. I just, let me see if I can get the case back up. For partial pulley tears, you might not have much bowstringing, so I don't really, I just eyeball it. For full thickness pulley tears, it has been
recording in progress.
It has been described in the literature. In this case right here, you can see the measurement was taken out compared to the normal, and so. And then finally, the last question, I'm going to read it again. Is it possible to see flexion deformities in cases of partial tears of the central or terminal slips? I would imagine that it would be. I mean, I don't know the direct answer to that question, but depending upon how much of the tendon is actually torn, I imagine that if it's greater than 50%, you probably would have some element of flexion deformity. It might be not straight on flexion. It might be a little obliqued, but that's my thought.
Okay, thank you. There's one more question from the audience. Are there any relation between FT sagittal slope with patella alta for Erin?
That's a good question. So that is a potential complication of removing an anterior wedge of bone from the tibia. You can get resultant patella alta. So that's a possible postoperative complication.
Okay. Rodrigo, have you seen this lesion you showed us in other sports here in Brazil? Because like the sports you showed, there are not common here. The only one which is common here is tennis. American football, we don't see here a lot. None of the sports you showed, actually just tennis. So do you see it often?
No,
not
no,
often,
no.
but
Yeah. It's about like the overhead sports here in Brazil. We have like volleyball, water polo, tennis, but they are all more controlled. So we don't see much of these lesions here. So this was a nice case because we are not so aware of all this throwing mechanism that the countries that have like sports with the throwing with throwing athletes, it's like soccer for us, right? There are some lesions in soccer that we almost when we were born, we already know what are the lesions. No, that's something that we don't have about the throwing. The throwing sports, the throwing mechanism is something that we actually have to speed up to catch the references and to understand better what's happening. And so here in Brazil, just more tennis, yes, for sure.
And thank God we don't have many grenades throwers here.
Yeah. Yes, it's like I couldn't put I didn't put that on the slide, but the baseball, it's violent, and throwing grenades, it's violent and desperate sometimes. So it's a step further.
Yeah. Okay, one more question for you, Rodrigo. In cases of stress fracture humerus, do you always ask for CT in order to rule out osteoid osteoma?
No. We just did that in this case because first his father, he's an orthopedic surgeon, and he's a close friend of us, and we saw that small dot on the T2, and we were a little worried about that, but so that's why we did the CT. Otherwise, if we will treat, like we'll let the patient rest for some time and see what happens. But probably we will in other cases we will not do that. We wouldn't do that.
Mm-hmm.
It was nice for the presentation, but
yeah, true. Yeah, okay, so I don't see any other questions here. Everybody's saying what a wonderful presentations. Congratulations for all cases. So, okay, thank you so much for tuning in today, and thank you, speakers. It was excellent, one of the best sessions I've moderated. And I'm looking forward for the next session, which will be held on February 25th. We focus on rheumatology. Thank you, and bye-bye.